introduce, my name is Peter Forsberg. I'm an assistant professor at the University of Colorado. I'm a plasma cell disorders specialist, so I'm excited to learn about lymphoid malignancies from our wonderful panel of experts today. We really have a world-class group of providers here to share information on a number of interesting cases. So I'll ask them to introduce themselves. Dr. Pagel.
I'm John Pagel. I am not a plasma cell specialist. I actually focus on lymphoid malignancies, really exclusively do research and, of course, patient care in lymphomas and CLL, and I'm at the Swedish Cancer Institute in Seattle, Washington.
Hi, I'm Michael Thurman. Thank you very much for inviting me to participate in this tumor board. I'm on the faculty at the University of Chicago, and I specialize in lymphoid and myeloid malignancies.
Pleasure to be here again. Thank you. I'm David Schuster, and I'm a radiologist. I'm Division Director of Nuclear Medicine at Emory University in Atlanta.
So this is a 69-year-old female with a history of relapsed refractory follicular lymphoma, initially diagnosed in 2010 and originally treated with R-CHOP for 6 cycles with a complete response. It relapsed 6 years later in 2016 and treated at that time with bendamustine and rituximab with a partial response, and now presents with worsening adenopathy and splenomegaly. So we'll try to run through a few questions in terms of, what workup the patient may need and beyond what we'll discuss is available now, what our favorite treatment options are, and what patient factors or historical factors may influence choice of treatment in this relapsed follicular lymphoma patient. So the patient was initially presented with lymphadenopathy, ECOG status of 1, history of some comorbidities, including diabetes type 2, hyperlipidemia, hypertension, obesity, consider a social history and family history to be non-contributory. Initially diagnosed in 2010 when presented with fatigue and diffuse adenopathy, 5 to 6 centimeter lymph nodes with splenomegaly, grade 1 to 2 follicular lymphoma was diagnosed, and the patient was treated with R-CHOP ×6 with a CR. In 2016, had recurrence with abdominal symptoms, abdominal pain, found to again have 6 to 7 centimeter abdominal nodes, splenomegaly, anemia with a hemoglobin of 9.6, treated with bendamustine and rituximab ×6 cycles, and achieved a partial response or remission with residual nodes of 1.5 to 2 centimeters. Now in 2019, so 3 years after most recent treatment with BR, presented with fatigue and a 20-pound weight loss, and on exam found to have diffuse adenopathy, supraclavicular, axillary, inguinal nodes, palpated to measure 5 to 6 centimeters. Labs at this time demonstrate a hemoglobin of 10, platelets of 110, which is down from patient's recent baseline, LDH, which is elevated at 300. And there's a CT scan of the chest, abdomen, pelvis, and neck performed, which shows diffuse adenopathy. Dr. Schuster.
Yeah, so we can see here, first on the left coronal view, there is extensive adenopathy in the retroperitoneum, right common iliac, pelvis, the rest of the pelvis, etc. And also we could see in the upper right-hand corner, there is axillary and mediastinal nodes, and then there's more axillary and the highest mediastinal as well. One of the questions was, what other additional diagnostics might be considered? And I think if it's available to you, I think this is where PET is really important. You're looking for a potential transformation and additional sites to biopsy, as well as more completely staging the patient. So that's my input on this one.
Great. Thank you, Dr. Schuster. Dr. Thurman, in addition to consideration of a PET, thoughts regarding additional diagnostics. Dr. Schuster mentioned using the PET potentially to guide biopsy to help confirm, sort of disease circumstance. Anything in that realm or beyond that you'd recommend as well?
Well, I agree that a PET scan would be very helpful at this point. So depending on the uptake, that would determine whether or not a biopsy would be needed to exclude the possibility of transformation. I think that's really the critical thing in terms of how to decide to go forward.
And if in the setting of confirmation of follicular lymphoma as the primary disease circumstance at this relapse, Dr. Thurman, your thoughts on recommended options for treatment?
Well, so there are so many options available now for treating relapsed follicular lymphoma. This is a patient who's heavily pretreated, who's received R-CHOP. So coming back with that as an option wouldn't make sense. There are some newer drugs that have come out, so I don't believe we know whether or not the patient has an EZH2 mutation. But if they did, and it was an earlier relapse, then EZH2 targeted therapies, tazemetostat, would be available. Even for patients who do not have an EZH2 mutation, who are in later relapses, and that's an option. There are a number of PI3 kinase inhibitors that have been studied in this setting as well. So I think there still are a lot of choices available for the patient that would be well tolerated and have a good option or a good likelihood for response.
Dr. Thurman, is it a situation where you would, the EZH2 status is substantial enough in terms of guiding the treatment decision where you would consider biopsying just to sort of evaluate that if it hasn't been evaluated before?
As I said, if the patient's only had one previous chemotherapy, then EZH2 status would be helpful because those patients are more likely to respond. On the other hand, since this is a later relapse, it's really not necessary to get a biopsy to find that out, since patients who do not have EZH2 mutations will also respond. So in this case, I would say it's not necessary. It's always helpful to have more tissue available, but depending on how accessible it is, it becomes less of a benefit if you're not going to act on it. So I think the key thing here is whether or not you need to do a biopsy to exclude transformation. And if that were the case, you'd get all the diagnostic testing. In someone like this, I think that you might just be able to proceed with another round of therapy without a biopsy if they have not transformed.
Dr. Pagel, any other thoughts about how to sort of maneuver with these variable treatment options that are now available in the later line follicular lymphoma setting?
Yeah, I think, really what we do, and, when Dr. Thurman says there's lots of choices, those choices really are chosen based on decisions that you make mutually with the patient, and what the goals are of the patient and what their comorbidities might be. All of those things come in and factor into decision making, as you know. I do think that tazemetostat would be an option for this patient. I probably would keep that a little more in my back pocket. That's a super well tolerated therapy, but it's of course something that might take a little longer to work. Here, this patient has some bulky disease, if I remember right. I would say that PI3 kinase inhibitors, as were mentioned, are a choice, but certainly not overly appealing to many of us, given the immune-mediated adverse events that can go along with those. We've talked a lot about lenalidomide and rituximab. I think that would be very reasonable here. The AUGMENT data showed us that adding lenalidomide to rituximab was better than rituximab alone in these kinds of patients. So I think R-squared would be very reasonable in this relapsed follicular case. Of course, there's tons of trials. We're very excited about bispecific antibodies for these kinds of patients. But one other thing that we need to start thinking about in these kinds of patients that we can now is CAR T-cell treatment as well. We have data, the ZUMA-5 data, that showed us really outstanding outcomes for patients with relapsed follicular lymphoma getting CAR T-cell with axi-cell. That's an approved therapy for these patients, and that might be something that we're going to think about for this patient as well.
You mentioned comorbidities potentially shaping your decision-making between, targeted options. In this patient who has diabetes, hyperlipidemia, any specific direction that might, point you in terms of things you would prefer or not prefer?
It's a really important question. And, you know, I think you have to realize that perhaps short of CAR T-cell treatment, this is palliative therapy. And what patients are very interested in is quality of life. They want to, of course, have good disease control, and they want to live for as long as possible. But if you're not going to cure them, they want to do it and live that life well. And I do think that tazemetostat is an ideal agent if it's appropriate for the patient who has a lot of comorbidities, because that oral therapy targeting EZH2 is super well tolerated. I mean, it's almost like giving a sugar pill. So the adverse event profile with that drug is better than any drug I've ever used in my 20 plus years of treating patients with follicular lymphoma. So the comorbidities play a major role in that way. And in this patient with those kinds of things, maybe they're not someone I'm going to be overly aggressive with and try to get them to a CAR. My overall, though, approach is to probably give R squared to most patients in front of tazemetostat. PI3 kinase inhibitors are off to the sideline in most of these cases now. And Dr. Thurman mentioned really quite appropriately, I think, in my mind, the responses with tazemetostat, EZH2 inhibitor, are really quite impressive if you do have a mutation in EZH2. So I might use that very early in front of R squared. If I knew that mutation was there, you have to test for it to know if it's there or not. If maybe the patient has wild type EZH2, I'd use R squared in front of the tazemetostat and keep the tazemetostat in my back pocket. Again, you can use it in wild type EZH2. And while the cohorts of patients looked at between EZH2 mutant and EZH2 wild type were very different, it does suggest that the wild type maybe doesn't have quite as good as activity in the mutant as the mutant population.
Great. So to summarize, you know, in this patient who's relapsing after prior treatment with R-CHOP and BR, now with bulky disease, the good news is we have a variety of different options to choose from. And, you know, it is one of those circumstances where shared decision-making with the patient and discussing priorities and the differences between different therapies is an important factor. But options including tazemetostat, PI3 kinase inhibitors, lenalidomide with rituximab maybe being a favorite approach in, you know, but depending on EZH2 status to some degree, and maybe to a degree, how much to focus on quality of life and avoiding toxicities, but also with the consideration that CAR T is an important consideration for folks with follicular lymphoma in this setting at this point in time as well.